Princess Jimmy. Good afternoon, everyone, and thank you for attending the March MAC meeting. We will get started in just a few minutes. As a reminder, if you are a committee member, if you would put your name in the chat to let us know that you are here. And if you are a committee member who is on the phone, if you would please unmute and to let us know that you are here, that would be great. Rachel, I'm still looking for another 1 or 2 more committee members to join for us to have a quorum. So maybe just give it another moment. Thank you.
Yeah, no problem. Thank you.
Okay, I think lots of people were coming on as I was speaking, so I think we've got the quorum now. Thank you, but I do want to just say I saw somebody else join on the phone. If you are a committee member, if you would come off mute and let us know that you're here. But we have a quorum, so Rachel, I will turn it over to you. Thank you.
Yep. All right. Thank you, Sharon. I appreciate it. Welcome, everyone, to the March MAC meeting. The first order of business is to approve the minutes for December 2024 and January of this year, 2025. So I will take any motion to approve or not approve those. I don't know.
Move to approve.
And does anyone second that?
I'll second that.
Perfect. Thank you. And assuming there is no one against that motion, then I think our minutes are approved.
Rachel, sorry,
Yes.
This is Dory. Who seconded that motion?
It was Joey or Joseph.
Thank you. Thank you.
Yeah, I know you need it for your notes. And then we have 2 reminders. So we are accepting nominations for the consumer rep for the Utah independent living center / individuals with disabilities. So I'm not sure we've gotten any applications yet. I would defer to Sharon on that one. But we're now accepting nominations. So if you need any information about that, I believe that was emailed out with our MAC materials yesterday. But if not, you can reach out to me or Sharon, and we will make sure that those nominations are submitted in a timely fashion. And we are also accepting nominations for the Beneficiary Advisory Council, which, as a reminder, is new and will work in conjunction with the MAC, and that is a beneficiary only council, operating like the MAC, but with more of a focus on beneficiaries specifically. So if you know anyone, or if you are listening in and you are interested, please reach out. We're still accepting nominations for that. Any questions on the nomination process or on the open positions, seats? Okay, hearing nothing, we will move on to our annual Open and Public Meeting Act training with Stephanie Saperstein. I believe I saw her on there, so we'll get started with that.
Good afternoon, everyone. Those of you who have been attending these meetings for a long time are familiar with my face. Those of you who are not, let me introduce myself. My name is Stephanie Saperstein. I'm an Assistant Attorney General with the Utah Attorney General's Office. I've represented Utah Medicaid for many, many years now. It's good to see some of you are familiar to me too from our other dealings. But once a year, the statute in the legislature requires the AAGs or someone to provide Open and Public Meetings Act training. Today, this is your annual reminder of the requirements that the MAC has as an open public entity. Utah Code, you do have, and I see it's on the screen, the handout we give out every year. I will again go through the basics very quickly. And there are no changes to the Open and Public Meeting Act this year, so there will be nothing to go over to update you on that. Okay, the Utah Code 52-4-104 requires that members of a public body be trained annually on the requirements of the Open and Public Meetings Act. The stated goal of this act is to ensure that the state, its agencies, and its political subdivisions take their actions openly and conduct their deliberations openly. It has been determined that the MAC is a public body as defined by the Open Meetings Act, and therefore is subject to this act, and why we are here for this training. The MAC meeting fits within the definition of a meeting in the act, which defines a meeting as a gathering for the express purpose of acting as a public body or a specified body to receive public comment about a relevant matter, deliberate about relevant matter, or take action upon a relevant matter. A quorum of the MAC members may not act outside a meeting to predetermine an action to be taken by the public body at a meeting on a relevant matter. So what this means is you can't in colloquial parlance, you can't pregame this meeting by getting together and discussing what you're going to discuss with the quorum. In order to hold this meeting as a public body, you must provide public notice of this meeting at least 24 hours before the meeting. The notice must include the date, time, and place, and include an agenda that specifies the topics you will consider. The notice must be posted on the Utah Public Notice website and at a location of the meeting, and provided to a newspaper or local media correspondent. If you hold regular meetings that are scheduled in advance over the course of a year, you must give public notice at least once a year of your annual meeting schedule as provided in the statute. Here's the key piece for you to understand. A public body may not discuss an item raised by the public that is not listed on the agenda. Oh, I'm sorry. Let me take that back. You may discuss it if it's not on the agenda, but you may not take a final action on the item. If it's not on the agenda, you have to put it on the agenda to make a decision for your recommendations on the next meeting for the MAC. You can conduct electronic meetings, hence that's why we're here. We are here where some or all of the members of your committee can attend through electronic video, audio, or both. As required by the Open Meetings Act, the department has adopted an administrative rule, and that rule is R380-42, which governs the procedures in conducting an open meeting electronically. At the opening of the meeting under this rule, the chair shall identify for the record all members who are appearing telephonically or electronically. Additionally, a member of the public body who participates in a meeting via electronic means shall be counted as present at the meeting for a quorum, participation, and voting requirements. If this committee meets electronically, the designated anchor location for the meeting is the Cannon Health Building, located at 288 North, 1460 West, Salt Lake City, Utah. A quorum is not required to be present at that anchor location. You do not need an anchor location if all MAC members attending the meeting attending the meeting remotely through an electronic video, audio, or both, unless you receive a written request at least 12 hours before the scheduled meeting time to provide for an anchor location for members of the public to attend in person the open portions of the meeting. So to restate, you don't have to have an anchor meeting if everybody is planning on attending electronically. However, a member of the public can request an anchor location for in-person attendance at least 12 hours before the scheduled meeting time. And in that case, those are held at the Cannon Building. This administrative rule, R380-42-4, also allows the person presiding the MAC to restrict the number of separate connections for members of the public body that are allowed for an electronic meeting based upon available equipment capability. I don't know if you ever get so big that you can't accommodate all people who want to attend electronically, but you are allowed to restrict it when necessary. Let's move on to minutes and recordings. The MAC must keep written minutes and a recording of all meetings unless the meeting is a site visit or traveling tour where no vote or action is taken. Minutes must include the date, time, place, the names of the members present and absent, substance of the matters considered, and a record of each vote. If you take comments from the public who are not members of the MAC during the meeting, the commenter must first be recognized by the presiding officer. The commenter's name and the substance of their comments in brief must be included in the meeting minutes. This is in accordance with Utah Code Section 52-4-203. The recording of the open portion of the meeting must be posted on the Utah Public Notice website within 3 business days after the meeting. Pending minutes of the meeting must be available within 30 days after holding the days. Approved minutes and any public material drafted at the meeting must be posted on the website within 3 business days after the approval. So you approve them today, 1, 2, 3, they have to be posted by Tuesday in order to stay compliant with the statute. Closed meetings. I don't know how often or if you ever have a reason for a closed meeting, but here are the legal requirements in order to close a public meeting. You may close a meeting by a 2/3 vote of the quorum present for discussion on the following: a person's character, competence, or health, pending or imminent litigation, matters related to the sale or acquisition of real property, the deployment of security personnel, devices, or systems, or deliberation and decision-making involving the procurement process. Those are the only reasons you can close a meeting, this public meeting. If you vote to close a meeting, you must announce and record in the minutes the reason for closing the meeting among that list of 5 that I've just given you. You may not take a vote in a closed meeting except to vote at the end of the closed portion of the meeting to close it and return to an open meeting. You may require, and again, I don't think you have ever had to do this, but it's allowed to conduct an emergency meeting, which does not require the 24-hour notice posted on the website. If unforeseen circumstances arise that will require you to consider matters of an emergent or urgent nature. However, you must first attempt to notify all MAC members and seek approval of a majority of your members to hold a meeting. I think that sums up everything in the Open and Public Meetings Act that apply to you. As I said, were no changes to this act in 2025. I want to remind you to strictly comply with the standards that I have just trained you on. If any of these standards are taken and they're not followed, one of the enforcement procedures with the sanctions of a committee is that anything you voted or acted upon without following the Open Meetings Act is void. So I would be careful. There is in the handout that's provided to you other penalties, which I didn't make notes on. Yeah, it's void, and it's a Class B misdemeanor to knowingly or intentionally violate the closed meeting provisions on top of that. Any questions? Okay, I will turn it back over to Rachel, and fate willing, I'll see you all again next year.
Thank you. Thank you, Stephanie, for that information. Always important. And I will turn it over to Jen and Eric for a legislative and budget overview from the legislative session.
Yeah, hi everyone. I will be doing this solo today. So Eric won't be joining me, and I will go ahead and share my screen. I have a couple, we will be sharing this handout later, so you'll have an opportunity to take a look at it for more detail. But let me get things brought up here, and then I'll go ahead and start walking through. Gosh. There we go. Okay, I'll start walking through the documents. So first, I'm going to walk through bills and walk through just some of the outcomes of the different pieces of legislation that passed. And then at the end, I do have some funding amounts laid out as well, so you can take a look at those. So again, for greater detail, you can always go into these hyperlinks or search on any of the legislative links for more comprehensive updates. For the sake of our time here, I just wanted to walk through the highlights of some of the different legislation that affected the Medicaid program and give you an opportunity to ask any questions. So first of all, I think we're starting here with what came out of HB 3, which is in some intent language. And this specific intent language asks the department. So you're going to see 3 things here, by the way. You're going to see bills, you're going to see some appropriations that came through EAC, and then you're going to see some intent language. And the reason we kind of bundled it all together is so you had a comprehensive look at sort of the body of work that came out of legislative session for us, and some of the upcoming things that you'll be seeing over the next year as we work on these items and as we implement them. So the first item I'll share is that in the June interim committee, we are asked to present a report on the likelihood of the federal government allowing a reinstatement of a work requirement for the Medicaid expansion population. So more to come on this later, because as I go through budget reductions in my director update, you'll see that work requirements are a focal point of the federal conversation. And so here, this is just asking, what's the likelihood of us allowing it? I think you all can surmise that as we report out on this, they may be mandating it, and we may or may not know that by June. But I think that's the direction the conversation's going. But that's the first the first request that came out. Next item, there are several different pieces here that we'll walk through with regard to some intent language. Let's see, the legislature intends that the Department of Health and Human Services report by July 1st on the status of updating the Medicaid preferred drug list and future year plans for additional classes and estimated savings. So this may have been a little bit cart before the horse, as it may potentially relate to an item we'll talk about a little bit lower around the hybrid unified preferred drug list. But it's also very important to look at pharmacy and understand the changing dynamic of the pharmacy benefit and how that impacts the program. So we'll definitely be reporting out on that. And then also here's another one that says we would like to report on the status of implementing the funding item, shifting all Medicaid dental to the University of Utah by June 1st, 2029 to the Social Services Appropriations Committee. So there is, you'll see here in the future, a report that will show a budget reduction option that actually does shift all Medicaid dental to the U of U, and we'll be doing a status update at that time. This item here, the next item, is asking the department by 2026, so not this year, but next year. They had us do a report. So these two, the items that I've covered earlier are reports, and they often take the reports that we present in our interim meetings throughout the summer and fall, and we'll look at those as opportunities for new legislation or maybe changes to our program. And so this step here is asking us to make changes to our urban and rural designations for counties. And they first asked us to look at whether or not we should reclassify and recommended reclassifying Washington County to an urban county. And when we do that, it can change. Why would we be asked to do this? When we're asked to look at urban versus rural designations, that can impact what providers get paid. So often in rural counties, for example, there may be enhancements for certain provider groups. And so when you look at the classifications, that's sort of what's prompted. So we initially last summer did a report out on Washington County, and it was limited to home health services alone. And then it was expanded, I think, for a later report. And at that time, we did not recommend changing the classification for Washington County to urban, but we did make a recommendation to Cache County. So that did pass. And as a result of that, it's asking us to submit a state plan amendment to CMS to reclassify Cache County as an urban county for physician and dental reimbursement. All other reimbursements are already urban in that area. And so that would then update that, and it would result in a cost savings, which I'll cover below. And that would be on July 1st, 2026. The next item, this is just intent language to increase funding for nursing homes and ICFs. We'll go through that further down the list. The next item is intent language that looks at pharmacy options. And there was a pharmacy study that I brought to you in prior meetings that was conducted maybe a year and a half ago now, that looked at potential changes to the pharmacy model. Today, the pharmacy program on the fee-for-service side has its own pharmacy program, but each of our 4 ACOs also have a pharmacy program. And so what this study looked at was whether or not we should keep them all separate like this. And while there are some rules that do align them, there was an interest in considering what options were to create further alignment in the program and or carving back pharmacy to fee-for-service. And what we ended up landing on is outlined here in this very long paragraph. I'm going to summarize it and say that effective January 1st, 2026, so just under a year from now, we will be implementing a hybrid unified preferred drug list for our pharmacy program for Medicaid. What that means is that there will be select classes of drugs that will become unified across all 5 pharmacy programs. And these will be meaning that they will be the same brand to generic coverage. So if fee-for-service pharmacy covers the brand name, then the ACOs will also cover the brand name. It aligns prior authorization requirements as well and utilization management criteria. And this will be applied to our ACO and UMIC books of business, not CHIP. The other step that this language puts in place is unified reimbursement for pharmacy providers, so that our ACOs also have to reimburse the pharmacy providers at the same fee schedule as Medicaid pays. So what that means is with regard to the ingredient cost, that's the cost of the drug, and the dispensing fee. So we are beginning our work on this already and are assembling a project plan, and we'll be working with our ACO partners on this, but that's the intent language, and this work will be in place January 1st, 2026. The next item that came through was looking at some existing money. It has long-standing, there's been about a $60,000 appropriation that has moved through the Medicaid agency and been directed to the University of Utah to support Prader-Willi, individuals with Prader-Willi syndrome, and to support those individuals in case management and other services. And what this intent language did is it split that funding up, and it continued to fund $40,000 annually to the University of Utah, and then designated $20,000 to the Prader-Willi Utah Association. So that is an existing program, but it's actually divvying up the money that had been previously allocated just to the University of Utah Department of Pediatrics, and is now giving some of that to the Prader-Willi Association. Okay, last piece of our intent language that we'll be looking at has to do with hospitals and looking at our DRG calculator. And essentially, when there's a hospital billed claim, there is a billing system that is able to calculate the cost of a service. And what this intent language is asking us to do is to switch the one that we are using today to a different type of calculator, which is called the All Patient Refined Diagnosis Related Group, so the APR DRG. And I think the reason behind this was to create a more cost-sensitive analysis for hospital payments, put more of the payment into the base pay rather than outliers, and it gets a little bit complicated, and some of that is explained down below. But there are some cost savings that are soon to be gained through this switch. And so this we put into place in SFY 2026. So that wouldn't be, I believe, until, not until, I'm sorry, 2027. So not until July 1st, 2028. Takes a while to do this work. But as a future item, that's something we'll start working on. Okay, moving on into bills, and if you have questions, go ahead and feel free to interrupt me while I'm presenting. Moving on into some bills, HB 282. This really truly just eliminated the sunset, the CHIP advisory group, which is like our MAC, but it's for the CHIP program, was set to sunset. And without, an ongoing date, it would have sunset. And so this just continued it, and it won't discontinue it in 2025. This next bill, HB 302, is minors in state custody amendments. And what this looked at, and it's a little bit complicated to think about, but essentially, this bill requires the department to, this is going to be a waiver that disregards certain federal benefits when determining Medicaid eligibility for minors and raising the resource limit for qualified minors. And so what that actually does in effect is also allows us to set aside some of the money that is put into some of these programs into like a college savings program, and it helps set aside some of the money that's allocated to the care of children who are in state custody to be able to be put aside for the child to be used at a future date. And so when we looked at this, the numbers that would benefit of this, those in JJYS and DCFS would be rather small, but still we see this as a program that we'll go ahead and begin implementing, and it does really kind of divert some of the money that would otherwise go towards those costs of services while they're in JJYS and DCFS, and puts it into a special account for the youth to be able to use at a later date. Okay, HB 310. I think this is the third year this bill came across, and it passed the finish line this time successfully. Disability coverage amendments. This bill also is an 1115 waiver, so it's another waiver. This allows, we estimate, about 30 people with disabilities who are working. They have income levels above our currently authorized thresholds for Medicaid to be able to access some wraparound services. So these individuals have to have a commercial insurance already. And then with this, they're working individuals who are on a commercial insurance, but they're above the Medicaid threshold. They would qualify for wraparound Medicaid services. So their income must be between 250% and 800% of the FPL. And of course, it shows the asset limit as well. It lays out some cost sharing requirements as well, but it allows individuals with disabilities to be able to get services like personal care, so they can have some assistance in their homes and just doing some of their activities of daily living. So we're looking forward to this, and are looking forward to also authoring that waiver in upcoming weeks. Okay, next bill, HB 347, Medicaid Social Service Program Amendments, does a few things. So I'll walk through what this does. So first, I'll say, and this was something we're pretty happy about, community health workers. This authorizes a group of community health workers to become Medicaid providers. So community health workers has been another item that has come up many years now in a row, but it has not been a funded item. And so at this point, community health workers have not been recognized as a Medicaid provider to enroll as Medicaid providers and function in that capacity. What this legislation allows is for the community health worker to be included as a covered benefit under the Medicaid waiver to serve around our reentry work. So it's not the full scope of services. We know and recognize the important role community health workers have for so many different activities around, just really helping Medicaid members and others access healthcare, understand healthcare, navigate the system, things like that. But this is some limited funding we got, but really important to be able to acknowledge the role of community health workers, let them be enrolled as Medicaid providers, and serve through our reentry work. So second item this bill covers, this is, okay, I'm shifting gears to pharmacy now. So in pharmacy, we've had a long-standing policy in place, statutory actually, language, that when psychotropic medications were placed on the preferred drug list, there was a special rule placed around psychotropic medications. So what are psychotropic medications? These are anxiety medications, anticonvulsants or mood stabilizers, as well as antipsychotic medications, antidepressants, ADHD medications, okay? So when these medications were put on the preferred drug list back in the mid 2010s, about 2016, I believe, 2017. At that time, there was a bypass created around preferred and non-preferred status. So typically on our preferred drug list, you have to try a preferred drug and fail it before you can get a non-preferred drug. It's one of the ways we've been able to create cost savings to our Medicaid members while ensuring really relevant, clinically, like highly clinically effective drugs are also on that preferred drug list. So this legislation actually, so when psychotropics were put on, it bypassed that preferred requirement. So people could just jump over and get a non-preferred drug. Okay. So again, this was a report that was put in front of a committee, I believe maybe 2 years ago, actually, that looked at the options and maybe cost savings of taking that bypass off on some classes of psychotropic drugs. So what this legislation does is on July 1st, it will remove the bypass for psychotropic medications except for antipsychotics. So it will stay there for antipsychotics. But for other drugs like antidepressants, anxiety meds, ADHD, and anticonvulsants, it will enforce a preferred, non-preferred pathway for these medications. And one of the things I would just like to share with the MAC is, you know, when we look at the number of medications available that are antidepressants, there's about 40 of them on our preferred drug list. And there's, 20 on the preferred side, 23, 20 on the non-preferred side. So these are classes that are rich with products, many of them available. So we will implement this on July 1st. The other piece is, what about people who are on non-preferreds today? We're grandfathering them. So we recognize they're maintained on a non-preferred drug. If they're stable and we recognize that, they can stay on that non-preferred drug. And then just like any other patient, when they're new to Medicaid and they're on a non-preferred drug, we give them the access to that because they've had continuity of care. So we recognize that. So there's still many pathways to get to that non-preferred, but this was seen as a cost savings and an opportunity to, also maybe gain, apply the PDL in these categories. One thing I want to back up to community health workers. This legislation will go into place by January 1st of this year. And so January 1st of 2026. So community health workers will go, we're looking at a January 1st date for that one. Okay. Next in Dunnigan's bill, it looked at cleaning up language around case manager certification. And then also some other items. It allows us to give a grant to Valley Behavioral Health, also a grant to Odyssey House, and then also directs DHHS to use over $1 million for a behavioral health skilled nursing facility. So a number of items here. Okay, next item. This is an SUMH item, but we wanted to bring it up as it really does affect and look at how children access timely access to healthcare services. And HB 365 requires substance use and mental health to submit an RFP for a study to look at wait times and barriers for a child to see a therapist. And so I think that work will be underway shortly. Okay, behavioral health modifications, HB 491. This looks at really essentially with this, as you all know, we have a number of state-directed payments that work between our hospital systems. This is an opportunity. You'll see this a little bit later when I look at some of the budget reduction options that have been proposed at the federal level. We use directed payments as a way to supplement payments, Medicaid payments, to some of our providers. And so what this specific legislation looks at is it's directing the department to create a directed payment for Huntsman Mental Health. It also sets up a directed payment pathway for the Utah State Hospital. The other piece I wanted to call out here is that this language, this bill also increases peer support rates in our state. So we know peer support specialists have also saw a rate increase for a few years now, and this will increase the peer support rates, and it also increases our MCOT team rates as well. And I have some more detail down below where you can see exactly what that is. There's some other things sprinkled in this bill as well, but wanted to make sure you were able to see at least those main highlights. Okay, next. Here we go. Visiting legislation we've seen in other years again is SB 284, Medicaid doula services. This is an item we've seen in our past, but this year is successfully passed. So this authorizes Medicaid to seek a state plan amendment to authorize doulas. This will actually do a couple things. First, it will create standards for training. So the department must establish training and registration requirements. So there will be some standards that are established for doulas. Then it also creates a pathway for doulas to register as Medicaid providers and be reimbursed for services for the pregnant perinatal population. So, okay, let's see. So, yep, I think the community health workers I covered up above. and that further intent language. Wanted to just stop and pause here for many of you who may be on this call who really help champion some of this work that advances our goals and initiatives of the Medicaid program, and just thank you for the work that you did. A lot of this was not governor, didn't come out of the governor's office, and the department didn't necessarily move out in front by supporting some of this, but certainly we're grateful for it and thankful for the work of many of you in getting this done. And we know, I'm so grateful for community health workers and doulas and increased rates for other programs and some of the ways we've been able to really bring things forward. Okay, I covered the intent language for the preferred drug list. I think I covered cash county already. So it looks like a little bit of duplication here with some things, which is no problem at all. I just want to make sure you're not missing anything. Last item, and this is the piece where, Eric would generally go through some funding. And I just wanted to give you a snapshot. When you look at, there's bills in here. I went through many of the bills. And so you'll see it's highlighted or it's not highlighted, but it's listed HB 310, SB 284. These other items came through EAC or they were budget reductions. So the red is a budget reduction or a take back. You'll see this in some places, the home health rate increase. The reason this is a negative is because we're not starting it until January. So we do our budget on a July fiscal year, July to July. So sometimes when you see these negatives, it's simply because it's money that's, we don't need a full year of funding. We only need a half year of funding. But the legislation put forth, so it had to account for that in the fiscal process. So that's why some of those say here. But let me make sure I just touch on a few things that didn't get covered up above. There was an RFA, a request for appropriation, that made it through, that did pass through EAC, looking at the coverage of anti-obesity medications. These are specifically GLP-1 agonists and the medications that are on the news for weight loss and are highly effective in assisting people to have weight loss. These have been we have 180,000 one-time funding. So this again was one of those interim legislative reports that was submitted. The amount that was requested was actually twice this amount. We got half this amount and for 1 year. So I have a meeting we're going to set up with the lawmaker, and we're going to talk through what this benefit will look like on a one-time basis and for half the amount. So there's more to explain on this in the future, and certainly our managed care partners are waiting for that as well. But that's just one piece. When you look at peer support increases, that's next on the list. You see ongoing, that will start at $30,500 starting in July 1 of this year. I talked to you about the savings, looking at Cache County. Let me see what else. This home health multiplier, I want to call out because we have had an interim report on this. I've testified to it a few times. And what this specifically looks at with regard to a $4.6 million general fund savings is the rule enhancement in San Juan County that was put on personal care services. So there's a rule enhancement for skilled and non-skilled services in San Juan County, and different zones of that county get a 7 times reimbursement and a 15 times reimbursement. So just to make sure you understand, you have the Medicaid reimbursement rate. Let's say that's, $1 a unit. And for that $1 unit, if home health care or personal care service are being delivered in either zone 1 or zone 2 of these areas, you get paid, instead of $1, the provider gets paid $7 or $15 for delivering that service in that county. This has been a very long-standing policy, probably more than 30 years, and it had to do with access to care and really being able to service people who were really, truly living on the reservation, difficult roads, things like that. But there has been a careful evaluation of non-skilled services, personal care specifically, where if that there was a consideration and lots of discussion around bringing that down to the regular Medicaid rate. And so that's I wanted to just walk through what that was. And then from that, there there also was a corresponding, just to be clear, skilled care like home health will stay at that enhanced rate, but personal care will come down to the usual Medicaid rate. There will still be a travel modifier you can add to it, but it's not that 7 times or 15 times amount. Next thing I wanted to call out was a home health rate increase. So 1.1 million was given to home health rate increases. And the COBE sort of outlines what sort of the listing of codes and the grouping of codes that fall into this. We haven't defined exactly where that money is going to be allocated. We're working on that and working with the association and just kind of doing our post-session analysis. But you'll see some increases moving forward to a variety of things, including personal care, waivered services, non-waivered services, things like that. Okay. The hospital Medicaid outlier payment methodology, that take back amount had to do with that grouper that I talked about. And so I wanted to just mention that the grouper that we looked at with the hospitals where we're moving from one methodology to another in upcoming years, that is what that funding amount is tied to. And I saw a question come through the chat. Let me just take a peek at this. Can you explain the home and community-based service funding transfer? Yes. You know, I believe this just was let me make sure my facts are correct. Brian, if you can back me up on this one, that would be great.
Yeah, I'm happy to. This is purely a line item transfer between our sister state agency, DSPD, and our own. It was only moving funds that were incorrectly allocated from the 2022. I think it was that legislative session, just moving it to the correct line item. So it didn't actually result in any additional funding. It's just moving between line items.
Yeah, and I probably should have taken it off here. I'm sorry. It's confusing that I presented it here. But you're right. It's the allocation between our line items. And I believe you're right, Brian, where one had been given money and it needed to be moved to another line item. Thanks for the question, Matt. Okay, let's see. What else do we want to? I think I've covered most of this. You know, these are some savings that were captured. And so those were savings from PDL management that were just brought back. I want to talk about this for a moment, if you don't mind. I would like to comment that while there was that $1 million amount given to nursing facilities up in the upper section that I had mentioned, there's an additional $2.5 million ongoing. Oh, now I'm like ongoing or one time, but an additional $2.5 million given to the nursing homes as well. And I believe this is ongoing. Brian, I'm looking. Thank you.
Yes.
Thank you, Allie.
Yes.
I think it's ongoing, but that's in addition to the million that was above. So just wanted to say those are two different items that the nursing homes and ICFIDs did receive. Last thing I wanted to mention was this item here is shifting Medicaid dental to the University of Utah. Right after I complete my presentation here, Brian is going to spend some time talking about adult dental, and that program is going live here in just a couple weeks now. It's hard to believe, but this was a funding, a budget reduction item that was put forth to the Social Services Committee that proposed taking the remaining of our Medicaid dental services that are in a managed care model. So those are for our children and our pregnant populations, and moving them out of the managed care model and moving them back to fee-for-service, which is administered through the University of Utah School of Dentistry affiliated associated provider network. And so this proposal had been put in front of the committee. And originally, the committee had gone back and forth looking at our current managed care contracts, and it had proposed a go-live date of 2028 for this future change. But at the end of all of the discussions that happened through legislative session, there was a proposal to actually move forward to move pediatric dental and pregnant dental, so our managed care dental, to fee for service through and run it through the University of Utah School of Dentistry Associated Network by July of 2026. So in just a year and 3 months. So wanted to just update you on that piece, because what you will see coming forward in future meetings are several 1115 waivers heard as public meetings. In fact, Rachel, we may have a whole meeting. As you can see, we have 3 that we need to work on between dental and our disabilities waiver amendment request, and then through our children and youth and DCFS and JJYS. And so we have 3, I believe, that we'll be working on, and then bringing, as they're ready, bringing those forward in future meetings. But I wanted to just share that as an update to what the legislation said, and then as it tallied out. Now, there may be some questions for folks on the call who may say, well, CMS takes too long. I mean, what if they don't get it approved in time? There's some language that said if or when CMS approves. So the goal date that we are working towards is July of 2026. However, if the waiver is not approved by CMS at that time, we will continue forward with our managed care plan, dental plan arrangement up until CMS does approve and we're able to transition the populations over. And then thank you, CHIP Dental will continue to be delivered through managed healthcare. So the CHIP program will not be changed for that. Okay, are there any outstanding questions or anything that my team would like to add that I may have missed as important points to present in that? Thank you for your time. That was a pretty long presentation, but I wanted to make sure you had the whole picture. And I think that did include, I included everything. So thank you.
Any questions for Jen? Jen, thank you. I personally appreciate the comprehensive review. If no one has any questions for Jen, then I think we can move on to a review of the dental benefit with Brian, which is also exciting.
Yes, thank you. Happy to be here. So just to frame, that was an excellent overview of the 2025 legislative happenings. The dental program that will go into full effect on April 1st. Most recently, the legislative action came from 2023, and then we worked on a dental waiver amendment that I'll be talking about, just the fruition of that implementation. So this has been an evolution over 4 different phases for about a decade now. We first started the expansion of dental for adults with disabilities in July 2017. We subsequently expanded the program to TAM adults that were participating in a substance use treatment program, and then to seniors. And now most recently is our largest expansion of the program is to 100,000 expansion members and some non-expansion parents. That will go live on April 1st, but you can see the member counts are located right around the dates for each one of these. So we are excited to add dental services for about 100,000 members newly beginning April 1st. This is thanks to a partnership that we have with the University of Utah School of Dentistry. One of the also benefits that we've been able to take is streamlining those 3 different steps of the program that were all approved as different waivers. We've been able to consolidate it into a single program and single benefit plan in our system. So that is a little bit more efficient. Now we have a single dental program for adults in partnership with the University of Utah School of Dentistry. Because of our arrangement, we do require that all providers that are getting reimbursed for these services provided must be associated with the University of Utah School of Dentistry Associated Network. So bottom line benefits for our members are that they can receive routine preventive dental care like checkups, x-rays, cleanings every 6 months, including fillings, root canal treatments, tooth extractions or dentures, as well as emergency exams and dental crowns. Those are the benefits that they'll be able to have available beginning April 1st. It is also important that I mention that this is a fee-for-service program to differentiate it from a managed care program. We in DHHS are the ones that develop the Medicaid policy around it, review the prior authorizations and approve those, as well as processing the claims and resolving any grievances that a member might have in the process. University of Utah School of Dentistry does help us by growing the provider network, providing supports, listening sessions, and serving as a community liaison for us. But most of the administration of it happens at the DHHS side of things. So we are right now rolling out the member communication. These letters are being sent to anyone that is expected to newly get the benefits effective April 1st. We have a Spanish letter and an English letter that are being distributed, I think, as we speak right now, as well as we will be doing some social media outreach and press releases in the coming weeks as well, just to announce this in more settings. Also, our Medicaid information bulletin is our main communication pathway for providers. We will be announcing it in the MIB, we call it for short, as well for providers. So this was a kind of a brief presentation, but I'm happy to take any other questions from the committee.
My question, so, and you might not know this right away, so don't feel like you need to answer it right away. With providers that are associated with either IHS or tribal facilities or urban Indian organizations, although I don't think they do dental right now, are they going to become affiliate providers as well? Is that kind of the idea? And then will what I wonder about is payment, because especially for, is it all going to come through the University of Utah School of Dentistry and then they'll figure out the federal part of it later?
So yeah, I can address those. So yes, we are requiring that they associate with the University of Utah School of Dentistry. That extends to all dental providers, including tribal dental clinics. We know that may have been slightly differently communicated in the past, but we are reinforcing that our CMS authority requires that. It doesn't affect the way that they're reimbursed. That has been a question that we've helped to clear up before. Like tribal dental clinics are reimbursed with an all-inclusive rate, so we've clarified that. But yes, that is a requirement. Sorry, I think I'm forgetting a piece of your question as well.
I guess my question was I guess this is the federal part, because it's a lot of the folks that they'll be, providing care to will be at 100% FMAP rather than expansion or traditional. So I'm wondering if the payment is still going to come from the university, and like that, the university will just figure that out themselves. Yeah, I can clarify that. So just as a reminder, so it is the DHHS that pays the claims, and we calculate the invoices. This is something that I didn't touch on in the presentation, but I think you fully understand that the University of Utah is providing the non-federal share for this program. So when we invoice them, we just naturally calculate based on the remainder that is due after the federal share is calculated. As you were mentioning, if a tribal dental clinic serves an individual that is a member of a federally recognized tribe,
then the federal government does cover everything. So there would be zero for the University of Utah to be invoiced for those services. But everything else that does have a balance of a non-federal share will be billed to the University of Utah School of Dentistry.
Gotcha. Okay, that makes sense.
Yeah, good question. Thank you.
Thank you. Sheila.
Hi, yeah, this is a great presentation. Thanks, Brian. I'm really excited about this. It's been a long time coming. It's a great benefit for Medicaid members. I'm curious, when you say affiliate of the School of Dentistry, so for example, Utah County, people living down there, how would that work? I'm just not as familiar with, like, how would how would they get the list of dentists available down there? What would that look like?
Yeah, it is a good question. And if you give me one moment, I can pull up the list of providers, because there really is a statewide presence on associations to the University of Utah School of Dentistry. They've been able to really leverage multiple partners across multiple counties. So it is a good question. A lot of times when people hear University of Utah, oh, that must be somewhat Salt Lake focused. We are getting associations with dentists across the state. So here is an example, and I will post this into the chat for everyone, because I think there was another question. But just all of the different providers, and this is separated by counties. So at the top, this is just Cache and Box Elder counties. But as you scroll through, it has additional counties. I believe you asked about Utah County, and I may scroll past it, but there we are. So Utah and Wasatch counties are grouped together and available there. So there really is a presence across all of the state, and hopefully that does give some reassurance about the access.
This is really great. Thanks so much.
Yeah, thank you.
I'll also add, thanks, Brian, that that this list is routinely updated. So you'll see it refreshed as they bring new dentists on board, and that they have new partnerships. I just got an email last week that there were like a dozen new dentists that joined over the last month. And so I think those will be added to the list, right? So I think that's just one really nice communication you can, this resource you can use in working with members, and use as a reference for you as well. I think, Brian, the other question had to do with the member mailing. And I don't think we're going to necessarily post the member mailing to our website, but Sharon, if you want to email Sharon Stegerwald, if you're not on that MAC distribution list, we're happy to share the member resources with you, the letter in both English and Spanish, and get that over to you. So Sharon, maybe if you can put your email in the chat, and then if people want to request them, we can make sure they have a copy.
All right, any other last questions? Well, thank you, Brian. We appreciate it. This is exciting. Like someone else said, it's a long time coming. I guess now we can move on to the eligibility and enrollment update. So Michelle, I'll hand it up to you.
All right. Thanks, Rachel. Hi, everyone. I will start out with just displaying here. Hopefully that's showing for everyone. The eligibility enrollment report for as of February of 2025. And I'm going to go ahead and drop this in the chat. This is available on our website. For those of you who are not aware, you're always welcome to go onto our website and find this enrollment report, and it gets updated each month. So as of, let's see if I can get my cursor to go there. As of February, the total enrollment count is at 353,163 individuals. As you can see, again, if you're not familiar, there's the interactive graph which shows you all these lines, and down here it's kind of hard to follow a little bit. So I'd like to go over to this data table, which breaks it down by program and gives you more specific information on each program. There's really no significant changes in enrollment to really point out from January to February. I will show, and I think I showed this the last time I covered this report, is that pregnant women on the pregnant women program has increased slightly, steadily since January of 2024. So you can see that's kind of gone up. Each of the other categories, there's really nothing real significant to point out. But again, you guys are welcome to go through this. And if there's any questions, you can reach out to me or anyone else and ask. But I'll pause here and ask if there's any questions or anything that anyone wants me to focus on. Yes, Stephanie.
Hey, Michelle, thanks. I was also looking at the other dashboard, the eligibility dashboard. So I just wanted to ask a question about that as well, if that's okay. Or I don't know if you know.
No, absolutely. I was going to pull that up too. So I'm glad you brought that up. Thanks, Beth. I can go to that. I can go to that now here.
Okay. Yeah, and maybe you'll answer this whenever you talk, but I guess I was just curious about whether or not I was just looking at, it just looked like there was like a bump at the beginning of the year, which I know like happens, but I just wanted to, because we didn't really have like the meeting in February, I just wanted to like, or we didn't go over this in February. I wanted to just kind of ask if, you know, if there's any, if that's like continuing, but also I wanted to know if they're seeing an increase in applications for like unemployment or other things. I've heard that from some people, but I just wanted to know if it's just like anecdotal or if that's just something that DWS is also noticing, and if we think that that's going to like also show some increases in applications for Medicaid.
No, that's a really great question. So let me first of all, let me drop this dashboard into the chat as well for those of you who are not familiar with it. This does get updated still every single month with information on renewal outcomes, and you know, you can click on each of the tabs that you can see at the top to get different information on the review outcomes. You can see we're still doing really well with our ex parte rates. I did want to point this out, and I will get to your question, Stephanie, sorry. I did want to point out real quick, this top part in the purple, percent of members where review has pended, you can see that's kind of increased since January. I just kind of want to point out that one of the new eligibility final rule provisions on ensuring we are improving transitions between programs was implemented in January, and we think this is a direct result of that, which is a positive thing. So I just wanted to point that out. But I know we have Melissa Presley, you're on the call. So if you wouldn't mind maybe answering Stephanie's question on the unemployment.
I don't know that I can speak to whether unemployment has seen an increase. I'm not familiar with where their applications are at.
Yeah. And just so you know too, on application activity, we do monitor here on this tab where it says other DWS eligibility activities. So here you can see applications, and this is overall applications, right? Not just specific to Medicaid. So if you do want to kind of see what's going on with applications, you can look at this tab and get an idea. You can see that, you know, we're up here these 2 months in December and January, and then just slightly lower in February. So I don't know if that answers your question, Steph, but
I wasn't sure if the unemployment was ever counted in that, just since it's like a different division. I don't know. It's always kind of treated separately.
Yeah, that is separate. So when we reference applications here, we are just talking about Medicaid, SNAP, childcare, financial.
Okay.
Stephanie, I will tell you, for all applications, we actually saw a decrease in January from where we were at from like October, November, December. Typically, January is a little bit higher, but we actually saw a decrease. And that's what we've at least seen the last few years is because that's when FFM open enrollment ends. So we did see a little bit, about 3,000 applications or so we went down for January, but that's including all programs. But UI is separate, and I'm just not as familiar with UI. So.
Okay. Okay. Thank you.
Okay. All right. Are there any other questions for me about this dashboard or the enrollment dashboard?
Well, I guess I kind of do have one more, and that was just like, so the application stays to decision, which I was just curious if that bump is also because of the other thing that you had mentioned about like trying to make sure people are like transitioning onto the, like, I didn't know if that would be like a similar reason or if it's like a rule thing or if it's just like, it just happens to be that way, but I just thought I'd ask.
No, I think that's a really great question. I think at application, potentially some of that could be. I don't know, Melissa, if you have different thoughts there.
You're just wanting to know about which bump are you referring to?
So these two for January and February, the increase in days to decision, is there a connection with what I was mentioning previously on renewal pending for January and February due to the final rule provision? And I don't think that this is connected to that. I think this is separate. So
Yeah.
I just wanted to see if you had different thoughts.
Yeah, I wouldn't say it's connected. So I could speculate, but I don't want to give you anecdotal. But I don't believe it's connected. No.
Okay. Great question though, Steph. Thanks. Okay. I'll pass it back to you, Rachel.
Thank you, Michelle.
Thanks.
And then I think we're going back to Jen for the director's report.
Yeah, okay. So thank you for another opportunity. This may take a bit of time to go through some of the federal changes to Medicaid that have been proposed. So I'll just warn you in advance. I have several things to go over just to prepare you for what's being looked at the federal level and kind of talk to you about what we're hearing on the federal side. So I want to walk through what the items are that are being proposed. I want to talk to you about what we're doing in response to this, and then also sort of like timelines and things like that. But before I get into that, I wanted to just take a quick moment and introduce the new Medicaid medical director. So Dr. Yoon Kim Butterfield has been our medical director for about a year and a half, and she left the organization about a month and a half ago or so. And we have hired her replacement, and her name is Dr. Ronak Iqbal. And so Ronak, if you could maybe take yourself off of mute quickly, I'd like you to introduce yourself, and Ronak's prepared for this, but if you could just give a few moments sharing with the MAC a little bit about your background and sort of your journey through healthcare for just a few moments, and then what brought you here to Medicaid.
Perfect. Thank you so much, Jen. Good afternoon, everyone. My name is Ronak Iqbal. I'm a physician with experience in surgery, internal medicine, geriatrics, hospice, and palliative care. I also have a Master's of Public Health and Global Health from the University of Utah. And currently, I'm working towards a degree in healthcare fraud and abuse from the Quigley School of Law at the University of Utah as well. I really feel fortunate to be able to serve the Medicaid population. I think there's a lot to offer here, and I'm really looking forward to learn under the guardianship of Jennifer, and looking forward to that mentorship. It's just my very first week, so I don't have a lot. I'm still in the process of onboarding and learning, and I'm happy to learn and sort of improve myself from everybody. Thank you, Jen.
You're welcome, Dr. Iqbal. So nice to have you here with us. And we're excited to have her show up, be present in more of these meetings, and many of you will get to know her. So Thank you. So I thought I'd start with that. And now let me move over to walking through a presentation I have for you. So just to kind of recap, I think many of you are aware we've had through, gosh, let me back up here and just go back and look at budget reconciliation. And through reconciliation, there were some high goals set with regard to some savings that could be put forth through the federal government, and bullseye of some of these savings happened to be the Medicaid agency. And so there were, prior to us really knowing which direction we would go through budget reconciliation, there was a 2-bill proposal put through the House and a 1-bill proposal put through the Senate, and both passed and made it through. And what they found on the Senate side had actually a much smaller Medicaid impact. It had about a $1 billion cut that they thought would be put towards Medicaid program and services. And the House bill, which was actually a 2-bill approach, had $880 billion of projected savings over 10 years put forth. And this had many different items that were very much focused on Medicaid embedded inside that proposal. Medicaid is not the only thing, but it is well recognized that if they're going to reach that savings threshold over that period of time, that Medicaid will be a key tool by which they're able to accomplish this type and breadth of savings. So I wanted to take a little bit of time first to talk about timelines and then go through what we had. So when we first learned about this, I believe I may have brought it to a prior MAC meeting last month, and I talked about it a little bit, and we were told from our National Association of Medicaid Directors, or NAMD, that we should be prepared. We needed to be knowledgeable about them. We needed to work up our different items. And then I also needed to work through and look at some of the cost estimates of them, and then work with our governor's office, congressional delegates, and so forth. And so we're doing that work now. Let me walk through what reforms are being considered, and I'm happy to take questions throughout, so you can stop and pause me at any time. And some of this will be a repeat of information I have covered previously, but I want to make sure that you're familiar with what's being proposed, and this doesn't necessarily like take you by surprise as it goes through. So first item that is being proposed. So what we did is we evaluated each of the budget reduction items that were at least put forth in the budget reconciliation proposals. And we've kind of outlined them here in this 2-page document, which I'll share with you afterwards. We also have much more detailed analyses. We have a whole project team and modeling that's being done, as well as 1-pagers and other resources that go into a lot more detail on these, and these are all being built. So first, I want to call out that at the very top of our list is rescinding or reducing the FMAP on our expansion population. So this is currently our adult expansion population has a 90-10 match, as you know, and this proposal is that they would drop the FMAP to the state's standard FMAP, is what we have heard has been proposed. And, in Utah, I think that the quick and dirty of it for us is that if that FMAP changes and this were to pass, that would enact our trigger law. And we are one of 9 states with trigger laws around their Medicaid expansion that would then tell us, okay, the trigger law has hit, you dropped your FMAP below 90%, the trigger law has hit. And so by the July after that bill goes into effect, we are supposed to be done with our expansion population. This would impact 83,000 individuals. And so we have here on the right, what is the estimated cost if we were to maintain these this population at current services. And so you can see some estimates that we have on the right-hand side, And then we're also looking at the total funds. If this were to go away, the fourth column, or column D, would say, what are the loss of funds annually to the Medicaid program if this program were to end? Now, if we were to dive a little bit deeper into this, in which I'm going to take just a little bit of time to talk about now, and a presentation that I shared last week on a legislative talk I was presenting on, I wanted to actually go through and share with you some facts about our adult expansion today. So today we have 83,707 adults enrolled in expansion and TAM. Okay. Now this budget cut proposal would affect adult expansion, but not TAM. So TAM would stay in place. But when we're looking at our 90-10 match right now, we know that the trigger law itself would affect adult expansion, but the trigger law is not for TAM, okay? So TAM could still exist, but at that lower FMAP rate. So what we know now, first of all, is that this population is really complex. So as we're talking, to stakeholders and congressional delegates and others, we have detailed documents really looking carefully at what the Medicaid benefit offers for this population today and what the demographics are. And I think, it's important to recognize, I say, like, the puzzle piece that Medicaid has in delivering care and services and filling gaps for this population. So first of all, of these 83,000 plus adults, our records show that 22,000 of them experienced homelessness, and more than half of parentless adults reported zero income. Okay, so very low income to homeless group. And yes, some of those are TAM, but there's a large portion that are also still enrolled in adult expansion. When you look at like diagnoses, and we've pulled diagnosis codes to look at the most prevalent diagnosis codes, I just have 2 listed here, but we have a list, 10 to 15 deep. But substance abuse is the most expensive service that is provided through the Medicaid program. We have about 19,000 plus members that receive substance abuse. Their diagnosis is substance abuse and deliver and receive services. Top 3 medications these individuals, the individuals use are MAT, again, substance use treatment, and then mental health medications as well. So second most common diagnosis that this group has, 30,000 individuals have mental health diagnoses. So you see here the kind of the complexity and the vulnerability of this population and the really critical role Medicaid plays in that. When we're looking, go ahead, Steph.
Yeah, and maybe this is maybe you were going to address this, but I'm just curious then if you think that if expansion went away but TAM remained, would there be a portion of that population that would transition onto TAM, maybe not naturally, but maybe because if they fell out of treatment, they would end up back in a situation where they would then qualify for TAM because of like those qualifying factors?
Sure,
do you think that that's likely?
We didn't model that, but we all know that's possible, right? As we think about Medicaid as being giving resources and treatments, and then opportunities, even some housing support services that are that important link in helping a person kind of step up. Yes, there's certainly that possibility that people could move from expansion today into that TAM category. Okay. Another really important lens here is to think about providers, because if this service and if this group, like adult expansion, were to hit that trigger law, for example, and end, then we have to think about providers and how those providers are being paid today, and how that would impact providers. Okay. So we have a breakdown just here on the right side of the screen, looking at the 1.457 billion in provider payments that have been paid to providers in fiscal year 24, looking at professional claims, nursing homes, hospitals, pharmacy, and dental. That's a really huge gap in some of the payments that are seen with providers, knowing that some of these providers are going to be seeing these individuals anyway if Medicaid were to hit that trigger law and no longer have adult expansion through other means, right? Through the ER or things like that. So we think it's important to be able to look at some of these pieces. The other thing I wanted to show as well, and this just talks about a bit of what we would be able to do. Just again, this is a different presentation. It's looking at our trigger law. And then there is in our current legislation a provision, not legislation, but in our statute, that if that trigger law were to enact, that we could implement a limited primary care waiver that would be similar to what maybe we had before, that for PCN, for example, but it would be limited, I believe. Brian, did we say, oh my gosh, now I'm forgetting, 13,000?
Exactly.
13,000 adults. Thank you, Brian, for helping me out there. That it's limited and capped in its enrollment. And so what we would do is if the trigger law enacted, we would have to then terminate adult expansion by July 1 of the year after. So if the federal fiscal year were to be the year that this bill would take effect, then we would have to end our adult expansion by July 1, at which point we have a provision in place to apply for a limited primary care waiver. And yes, what we're seeing is it would be similar to PCN, is what Brian and I have discussed. And that was the thought process when adult expansion came online, that there would be a bit of a fallback to the pre-expansion state, right, where we had that PCN benefit. And then, of course, and what we estimate that all in all, it would cover about a quarter of the expansion group that is served today through this benefit. Last, one thing I also want to just highlight is we have to look at the policy impacts. We've been very fortunate to be able to get some housing and HRSN waiver and some housing supports, justice reentry waiver. We see that that the Medicaid housing supports would be eliminated without this. And the whole Medicaid expansion fund is another piece of the discussion, is that wasn't captured in the statutory language. So how is that managed? What would happen with those funds that are in the expansion fund? Regardless, from a policy perspective, we do see that the Medicaid housing supports would be eliminated, and the justice reentry waiver would be substantially reduced or potentially eliminated because of these changes. We also, as I mentioned earlier, the local authorities as well as the hospitals would have to bear a lot of uncompensated care or additional costs, because again, you're shifting those costs back to the county, where that right now they can be serviced through the Medicaid agency. Any comments on this before I get off of this slide deck? I'm going to go back to my my other presentation. I wanted to just spend additional time on that to let you know that in our modeling, we're thinking about a variety of scenarios, right? Our governor's office and our lawmakers may be asking us about a variety of positions. What if, what would it cost to go down to that regular FMAP? What would the cost of that be? How would we sustain it? Or a variety of changes, like what would the expansion fund do? How long could that last? And I think just, quick answer to one of those questions, even if we're not quite at $400 million in the expansion fund today, but if that FMAP were to drop, you can see right away it would use up that expansion fund pretty quickly. And so that it would require a substantial general fund investment. But again, I think, yeah. Anyway, any other comments on that?
So, thank you for this, Jen. So, and maybe this is kind of the point that you were making a moment ago, but what do you do with the justice waiver? What are,
yeah.
It's just there's so much going on that you guys are doing, and it would just be so disruptive.
Adult dental. We're excited to launch adult dental here, right? And so, I think it's been really important for us. And I know I have, several staff on the call right now, that amidst all of this conversation that's happening at the federal level, we are very engaged and informed about what's happening, but we are very focused on our work going forward, right? And so our staff need to know that this is a proposal. It's not our reality. And so we are planning, but it's also important to educate, right? So be important that we've done our modeling, we have our resources developed, and that we're ready to talk about it. And I know many of you have been out as advocates, speaking with decision makers and stakeholders as well. But for our team, stay focused on our work. You know, it's really easy to get a little stressed out. And that doesn't mean we don't get a bit of anxiety about these proposals, but we stay forward focused because we have people to serve. And right now, the policy says we're serving them. And so that's our work, and we're focused forward on that. And I think the team's doing a really good job. But you're right, there's a lot wrapped up in the expansion fund and the services around this population.
Yeah, thank you. And thank you to your team. I have another clarifying question, I guess, is just like, you mentioned that you've met with some members of, I think you said this was part of your legislative presentation. So I'm assuming that was to members of Congress or their staff. Something that came across as some of us have met with some of their staff is just, there seems to be some misunderstandings around expansion. And so I really appreciate what you all did to try to capture the, health conditions like the medication and things like that. Something else that, is something we dealt with a lot whenever we were working on expansion, but like, it's just, they think that like these people can get coverage on the marketplace. And I just, I don't know if they really understood how much of that is like not the case for, like that was the whole point of Medicaid expansion, is because it was a coverage gap. And so I just wanted to bring that up as just like something that has come across a few of us, and just, for you or for anybody else that wants to know that might be an area where just understanding that for many of them, they'll be uninsured. And so, maybe they'd be able to transition to TAM or a PCN program. And maybe depending on the situation, they could find their way onto the marketplace. But for many of them, it sounds like they would just be uninsured. And what that would do, obviously, to like the behavioral health infrastructure that got built up because of like TAM and expansion. So just, anyway, that's just something that I think they might misunderstand.
I think a broader conversation, like this is the Medicaid impact, but how does it affect the state more broadly? And I think those are conversations we're engaging in as well. And so I think that's a really, really important point around building up the infrastructure and what we have today. One thing I will say, and I'll just share what I've heard, because I don't have a direct line to Congress or what's going on. And you and I all know that there's lots and lots of activity, but I am in regular meetings with NAMD, and I'm serving on committees where I'm getting to talk about these things in detail through their board and through different work that I do. And I'll just say that some of what is being shared to NAMD and to other Medicaid directors who are meeting like in Washington with these folks and the people who are doing this is that some of the goals and objectives, of course, are to shift some of the federal spending to the states. But it's also been emphasized to us now in more recent discussions that they're looking to focus more on controlling the rate of growth in Medicaid rather than cutting Medicaid, if that makes sense. And so as I've been in now several weeks of discussions around all of these topics, I'm not seeing this topic come up as like the hot thing everybody wants to pursue. And I'll just tell you, because I may or may not have time to make it through all these today. And I want to emphasize this for our state because it has such a big impact. If it were to go past, it's really important. Like, we're thinking about this, we're working on it, we're thinking about it from, at the human level and what they're utilizing and sort of like how the service needs are being met today. And then thinking about what, alternative options look like, right? So I want you to know we're doing that work, but I will tell you, one of the things that we're hearing, and I'll just say like my slide deck had FMAP changes and taxes, because the other piece that is being discussed heavily are tax reductions, which I'll get to, and I'll walk through provider taxes here in just a moment. Work requirements mandatory work requirements are heavily discussed. And I think we can anticipate that is going to be something we will see working through, as a priority. The other piece that we are hearing more recently is repealing the eligibility rule and the nursing home staffing rule that came out with the Biden administration. So the eligibility rule, Michelle said earlier, hey, we already implemented on January 1st this piece of the eligibility rule. Some states, we already have a roadmap for doing several of those things, but there is interest in repealing the eligibility rule and the nursing home minimum staffing requirements. So Allie, if you're on this call, might be good to hear that as well. And that is of high interest. And that has about a $200 billion savings tagged to it. So if you look at that $880 billion mark, we're being told that has about a $200 billion savings tied to it. Work requirements, I know that's all over the map, right? We're like, work requirements don't save money. They actually, cost and things like that. But they're at this point, they have about $120 billion tagged with that. So, and there's so much more to get into about this. But I'll say, we're looking at all of these options, but this week, where people are speaking directly with, people who are leadership in the Senate side, leadership on the House side, and talking to them about what's coming up and what are really focus areas. Other areas, and let me just run to the tax since I touched on it. There's an interest in limiting the provider tax or having a provider tax reform and taking it from that 6% threshold down to, and I have 2.5% here because that was in a CBO report from some time back, but they're looking at a 5%. What does a 5% reduction do? What is a 2.5? What does eliminating it entirely do? Right. And so for this group, maybe I'll just pull up one slide here. Again, taking my slide deck that I prepared from last presentation I gave on a national meeting last week that looked at what we have. What does that mean to Utah? So Utah currently has 4 provider taxes, and you see them listed here. Hospitals, and what are Utah's current level of tax? Okay, so right now we're allowed to tax providers up to 6%. Hospitals are at 4.4%. Nursing facilities and ICFs are at 5.96%. And ambulances are at 4.2%. So an estimated reduction to provider taxes, if it were to go, for example, our model supports a 5%, 2.5%, whatever, different types, but that would, it would drop and create a reduction in what we have by about $95 million to go from where we are today to 2.5%. That would be a $95 million impact to our providers. If it were to eliminate it entirely, it would be a $381 million impact. So, and again, the image on the right shows sort of the illustrations of the base payment and how the provider tax fits on top of that. So we're modeling out those, and the discussion I was part of yesterday talked about they may not have a uniform reduction across all different providers. So for example, if they were to say, okay, we'll get rid of the minimum staffing rule for nursing facilities and not mandate that, then that sort of trade-off would be the nursing facility taxes would drop from a 6% down to a different percent. And so there's, that's kind of what happens, right? Like they're talking, and what I'm saying today could be totally different tomorrow, frankly. But just wanted to share with you and give you the latest on what we're hearing. Let me jump back here quickly to make sure you are aware. I think I covered these again last week. Steph, did you want to ask a question? Stephanie, you came back on camera, but I didn't pause.
Oh, well, it's okay. I can hold my question.
Okay, I'm happy to answer it.
I'll wait till you're done, but thanks, Jen.
Okay, sure thing. All right, so other things. Another proposal is dropping today on our administrative side. So for administrative services, there are a variety of things that typically it's a 50-50 match where the state pays 50% of the costs and the feds pay 50% of the cost. But there are some services where we get an enhanced federal match. And this proposal proposes dropping that enhanced federal match and just having everything at a 50% match. And so this would have a direct impact on us of about $18 to $19 million. And we have this as a mandated backfill. So that would be a GF impact, a $5 to $6 million expansion fund impact. And we would need that. This is for, clinical services, mechanized claims, and some of our APDs that we submit to CMS get some enhanced funding. So with that, now the next item looks at, they kind of go hand in hand. When you look at the provider taxes and limiting state directed payments, they are related items on how we kind of add these sort of enhanced rates onto sort of the base payment rates that providers get. And another proposal is looking at reducing the ceiling of the state directed payment down to a Medicare ceiling. So today, for example, our hospitals have been paid through a directed payment modality to the average commercial rate. And this is, of course, about $400 to $500 million is what we have here on our right-hand side. Now, the hospitals pay the state general fund part of that, but we do pull down about $400 to $500 million in, well, several hundred million in federal fund. And so with this, dropping down to the Medicare, it would be an impact in the ballpark from taking from ACR down to Medicare, ballpark of about $400 to $500 million loss of revenue for our state with that proposal. Okay, let me go through a couple more here, and then I can, I think that was the bottom of that page. There's two items that look at sort of a fixed amount that a state would get. And these proposals look at giving the state a calculated, I guess, base amount of funding, or I shouldn't even say a base amount, a set amount of funding, using a per capita cap approach or a block grant approach. These both, the per capita cap is something that we have a little bit of experience with our adult expansion population, but this approach would apply more broadly to our entire Medicaid population this go round. The block grant also would put that fixed amount of federal funding that we receive in a block grant for our entire Medicaid program. One of the things about per capita caps that we have heard that there is a lot of discussion around per capita caps and how some states have been able to think about, like Tennessee has an interesting per capita cap model that is kind of a hybrid per capita cap. It's not a pure per capita cap model, but there has been a fair bit of interest in per capita cap, and there's lots of discussion around what this would look like. We've modeled per capita caps. There are, it's not clear the different parameters that need to be plugged into a model. Like, what is your base year that you would use in that model? And what, for example, are the variables with regard to the inflationary factors and other things. But what this does is it takes a per member amount of spending, and it creates for your Medicaid program from that base year and an inflationary amount and those types of things. It establishes a per capita cap base amount. And then from that, you get some changes to the funding based on your enrollment. So if your enrollment goes up, you can get more enrollment. You can get more money from the feds. So it's a little flexible around enrollment and inflation. It would also go down as well as inflationary trends change and enrollment changes. It would go up or down based on those factors. So it does build those pieces in. However, with both of these approaches, our concern is it limits like program growth because you're working off of a fixed amount. And when we're looking at new policies or changes, and, in my mind, we were given many different federal rules last spring that were unfunded mandates. How do you do that in a per capita cap or block grant model when you're looking at significant program changes and costs? And how do you do that when you have a fixed amount that the feds are going to give? And how do you even from a state budget perspective, really try to, it really can possibly really limit the program as well. So I think I'll just say we are hearing per capita caps is being discussed, but in my most, recent meeting as of yesterday, the taxes, pulling back those rules for eligibility and nursing home staffing, and then mandated work requirements were really top of list from what the staff had brought back from their conversations. Any questions on those?
I guess I jump in now then, Jen. I'm wondering, so the Maryland model that's like, I think CMMI has called it the AHEAD model or whatever. And of course, like the
AHEAD model.
Yeah.
Yep.
And I'm just thinking back to like the committee hearing where, that in interim where that came up and how it was surfaced that it was the hospitals, were opposed to the idea. And that's why it wouldn't go forward. And so I guess I'm just like, that model does cap the growth as far as the cost, right? So it allows hospitals cannot exceed a certain target for how much they can grow like in their revenue. I'm just trying, so like, is that what you mean whenever they say they're talking about like capping the growth, or do they mean the growth as in beneficiary growth?
Yeah, so I think it's expenditures, okay? The model itself can, as beneficiaries, so per capita caps, for example, does a per member, and Brian, help me out here. Brian's actually done this work. He knows the calculations, but it's a per cap, like each member has a per capita expenditure that in that base year, right, we would be calculating a member cost, and then holistically for the program, that would be your federal funding based on that kind of base year. And there are other factors to it. Brian's going to add in here in a second. But the beauty of the per capita cap compared to block grant is the per capita cap funding. Let's say they give us, $4 billion, right? And this is what our program costs based off of this year. If our enrollment grows in the per capita cap model, if the enrollment grows, we get to increase our federal funding because it adjusts the model. If you read here, it would, it doesn't say it in here, but it seeks, it allows increased funding for increased enrollment, but it also reduces funding for decreased enrollment, right? But it adjusts based off of enrollment factors, which makes it a little more sensitive to, economic changes, for example, right? But it also can change for inflationary factors. So whether that's, whatever the inflationary factor that would be selected, it can adjust. Block grants do not change your funding based off of enrollment. So enrollment could go up or down. That's okay. All you're getting is $4 billion. That's all you're getting from the feds. And then there's a factor for inflation that's put in there, but there's no enrollment change factor. Brian, what else would you add to that?
I think you covered it quite well. But yeah, just for the group understanding, Utah has some experience because back in 2019, we were directed to apply for a per capita cap waiver. So we have some experience because we proposed a model. It did not get approved. CMS at the time did indicate that it was not approvable, but the recent actions at the federal government could change that. But yes, at the core of it, it functions on a per member per month basis, and then a limited inflationary factor. It's typically based upon consumer price index changes. So they may say they allow for like 3% growth year over year, and so if our per member per month is $1,000 in 2025, it may just grow by $1,030 in 2026. And so there's a massive calculation we could do at the end of 2026, divide our total costs by our members and months, And if we're above 1,030, we wouldn't get federal funds for a certain portion of those expenditures. That's the idea behind it.
Yeah. Oh, thanks, y'all. I mean, I track what you're saying. I guess I'm curious if there was any, because so essentially though, what that can lead to is the repealing of Medicaid as an entitlement. And I understand that for expansion, it's technically not a legal entitlement, I don't think. I guess Andrew Riggle could tell me if that's incorrect. But for like the traditional Medicaid population, I mean, Medicaid was it's an entitlement. They have a legal right. It's why if somebody is denied and they were eligible, there can be like a legal process by which they can become enrolled. And I know that like whenever they're going to start capping enrollment, like that's what it would lead to, is like you could have a person with a disability who is denied access to Medicaid simply because that enrollment number would have already been hit in like the conditions where there would be enrollment caps, which is just like, you know, a non-starter. But like
Steph, just to be clear, it doesn't put an enrollment cap, it puts a funding cap. And the state needs to pick up those extra costs, right?
The state would create an enrollment cap. Like if
I understand what you're saying. And I think it's a good perspective to share, you know, and to recognize that. But that's, you know, I think as we analyze these models and you see, we've spent quite a bit of time, we have actually a good model for this bill, and we have a model bill, and our analyst who's been working on this really can build in, well, what if this happens and this happens, you know, so we can look at this, and Brian's been very involved in that as well, that modeling work. But I think it's really important as these topics come up and we do a deeper dive into what is the impact, what does that mean to us as a program as we know it today? And if you put the whole program on a per capita cap funding model, what does that mean? And I think playing out those scenarios, even like you're thinking about, or we're thinking about policies and, you know, how you make it all work. That's the exercise we have to keep going through as we look at these different items, right?
Yeah. And I appreciate that. I guess so my question, I guess I'm just curious about whether they are having conversations. I mean, I see that you've got like the DSH reform and like there was the other hospital payment reform one. So those would obviously go at what I was mentioning earlier, but whenever they're talking about the reductions and the growth, is it only through the mechanism of per capita cap and block grant, or have they looked at like forcing every state to adopt that model that has like trimmed down expenditures in Maryland and Massachusetts and things like that? Or is it just like through these other, you know, mechanisms, or is that something that has come up as well?
Within the items, I mean, the Maryland Ahead model is a demonstration model, right? That is not like well established at this point. You know, it's like, I think, a 10-year demonstration program. What is on the table through budget reconciliation are these items right here that we're talking about, and then some of these other pieces of legislation that came through, like the eligibility rule and things like that. A lot of other things could come up, I'm sure, but I'll tell you like what came through the formal process, and really what are very much focused on are these items. That's what we're focusing on as new things are introduced that aren't on this list or are different than what I've presented. We will pivot, right, and make sure that we're aware and engaged on those impacts as well.
Okay, thanks, Jen.
You're welcome. All right, just to wrap this up, I think I mentioned already work requirements, community engagement requirements, and that there is strong interest in making these mandated. That we had an extensive discussion yesterday around what that means, and with regard to exemptions and or pathways of support, and how much credit. We got into the weeds a little bit yesterday. I was on with a group of Medicaid directors that are working on this topic and talking about and trying to, think about the various tools that are being discussed. And I think, Stephanie, the one thing is like, we need to educate people so they understand, right? And so this is very in the weeds. And I think the directors who've been to Washington and are making those visits with lawmakers, you know, what they're saying, and some of these are people who've been around a long time, is that these lawmakers are a lot less savvy than they were even in 2017. And so it's really important for like us to educate, right, those decision makers and spend our time really helping them understand what these impacts are, right, and how they influence like their communities, really, at the end of the day, their state and their local communities. So, all right. Last couple of things I just wanted to share with you are things that we've assessed as not impacting our state, would be the DISH reform and the FMAP floor. We don't see the DISH reform as being an impact because while we do put DISH payments out, those are all collected back through the audit process today. And so we don't see changes in this area as being a negative impact to Utah. And then the FMAP floor is, you know, within what a state match is, the floor of the federal match is 50%. There are 11 states who are at that FMAP floor right now of 50%. And they're talking about reducing that. And if your state economy is very strong, should the feds be paying for 50% of your Medicaid expenditures, or should the state be paying more of that, right? And the feds be paying less. So that is certainly an option too. There are, of those 11 states, I think I mentioned last time, but I believe 10 of them are Democratic states and 1 is a Republican state, Wyoming. So any outstanding questions on this? Okay, as we hear things, so what is the timeline? I think that's the last message I want to leave you with, because we've done some work. It's kind of, they keep saying on our federal calls, hurry up and wait. But really, I think it could happen quickly if it does. There's been conversations that after Dr. Oz is confirmed, that there may be some quicker action and we may see something before Memorial Day recess. And then there's other conversations that say we may not see anything until the August recess. But I think that based on the degree of conversations and where they're going, that, you know, it may not be too long until we have some more information. Like we'll have more information each week. So each month when we meet, I'll make sure to bring it back to you and update you on what we're working on. So I think that's my update today. I know we're almost out of time. Thank you for your patience. This is a lot of info. I hope it was helpful to you. And know it took a lot of time to go through, but I appreciate your attendance and, you know, just learning about it.
Yeah, thank you, Jen. One thing, and again, you may not know the answer to this, is one thing that we'll be looking at into the future is, I know that I can't remember how it was done, but there's some adjustment to the public comment process through HHS, and that many things are not going to, that have been subject to public comment through HHS. It might affect all agencies. I'm just hyper focused on one, right? We might not have that public comment at the federal level. So I was wondering how that, if at all, affects the state level. Again, you might not know that right now.
Yeah, thank you for the question. I saw your question and we need to research it a little bit more, but right now for our agency, nothing changes from public comment. Cool. We will be going through the same public notice, public comment period as we have in the past. I'll also share with you that we are now engaging in conversations with CMS. They're seeking to meet with us weekly. They can't make decisions on things yet. And they're, you know, Drew Snyder has just like been put in place now. And he's, I think as they're figuring out their communication and what their leadership direction will be, we'll see more action come out of that. But we are in regular meetings with CMS now. I was in 2 or 3 this week already, or 3 this week already, I think. So I think you'll see more engagement from CMS, and that, well, we are seeing that. There's just more, you know, we haven't had any like really good, like a lot of decisions come out yet.
Cool. Well, thank you. Does anyone have any other questions for Jen? I know we're almost out of time, but. And then I think last thing on here is committee member updates. Again, we're almost out of time, but if anyone has anything. All right. Hearing nothing. Our next meeting is May 15th, from 4 to 6, which is different. This is the budget recommendations meeting. So if you have those budget recommendations, send those to Sharon, right? Right, Sharon?
Yes, that is correct. If you want to sign up to present a budget recommendation at the May meeting, if you would please get in contact with me as quick as possible so that I can give you all of the information for that. And so yes, thank you, Rachel, for mentioning that. There is a time change. And if you want to present to, please contact me. Thank you.
Steph.
I realize this is going to be an unpopular comment, but I guess this might be actually my last meeting, so I'm going to say it. But I feel like we should not be doing every other month whenever Medicaid is like having so much go on. And I really wish that we would move back to monthly meetings because, like this is like one of the most important issues going on in our country right now. And I think that this committee has a lot of value. And I know that there were several members of us that worked really hard defending Medicaid against legislative attacks in our state. And I think that we have the power to continue to do that at a federal level. And I hope everybody continues to do that. But I just feel quite strongly that we need to have monthly meetings while Medicaid is under attack until things are in a more secure place. But I couldn't not be on here today and not say that. And also, anyway, yeah.
Would that be like a motion that we should discuss, or is that not the motionable? Because I sure would support that motion.
I think we can. Oh, sorry, Rachel.
I was going to say, according to our training earlier, we can't take final action on that, but that is something that I believe we could probably vote on quickly at the beginning of the budget meeting, given how crowded that meeting is, to say the least. But Jen, if you want to.
Yeah, I'll just say, and Sharon helped support me here with regard to the bylaws. The bylaws outline a minimum meeting cadence. That does not mean we can't have more frequent meetings, okay? So remember, during legislative session, we chose to have that meeting, even though we couldn't get a room. There was still interest in us getting together. So while it's laid out at a less frequent cadence, because sometimes, you're right, it's a very busy time right now. And so I think, and not that, right. So bylaws have a minimum requirement. That does not mean that executive board here cannot determine that we would want a different one and set up, or, like the agency could ask for one. Stephanie, you're asking for one as a committee member. So I think, I think that's something I would just say, I think the bylaws lay out the minimum standard. That does not mean we can't have more frequent ones.
Great. Then I would like to propose that we get one in April. So I will let you all on the executive committee discuss that, but I would guess that a lot of people would agree with that. So anyway.
Yeah. And I
meeting in April as well.
Yeah. And I think what we can do is, and we can discuss this in executive committee, is decide how we want to proceed with a meeting or not. Jen's right. There have been times where we might not have had as large of a need to meet. And I think the idea was also with the back being in place as well, it would be tough on those back members that were also MAC members to meet at that frequency. But I also agree that like right now, I would probably like to see a meeting in April and probably monthly going forward, especially that the back, to my knowledge, is not meeting right now. But Sharon, I know we're at time now, so.
Yeah, so I just want to clarify that the back does not have to meet every month that the MAC does, right? So the council does not have to meet every time that the committee meets, right? The council, so just because MAC and BAC sound so similar, I'm going to say council and committee. Okay, so the council can still meet quarterly. That has its requirement. And then the committee can meet more often. So I just wanted to make that clarification for that. It doesn't have to meet the same time that this meeting does. Thanks.
Okay, so I guess my last question, since I know we're at time, is if we wanted to have a meeting in April, A, is that possible? And B, can we do that without a motion or anything like that, given that we, I guess I'll let someone answer that for me.
I I think if we meet public meeting notice requirements,
Correct.
I think we would be fine to host a meeting in April, and Sharon can look at our usual Thursday afternoon and see what's going on at that time. And I would suggest that we would take that place on the third Thursday of the month, and look at what that time could look like. And we can certainly, we'd go through the whole public notice and follow that procedure. But I think that's how we would go about doing that, Rachel.
All right, well, let's do that. And then I think in executive committee, we can dedicate a chunk of time to talking about how we want to go forward with deciding on meetings or not, that kind of thing. And with that, I know it's 4:02. Does anyone have anything else? But yes, if you have any budget recommendations, as a reminder for those of you who have not had the pleasure of participating in a budget extravaganza before, if you have a budget, if your organization has a budget item that relates to Medicaid that you'd like to see funded, this is a really good way to, get the group to talk about it. Everything gets voted on at the next meeting. And this kind of helps, especially if you're looking to get something in a governor's budget or in the final budget. I mean, that's obviously the goal here. Please submit your items to Sharon. And with that, I think we're good to go for today. Thank you, everyone. We will see you in April.
Thank you.
Thank you. Thanks,
Bye.
everyone.